Good afternoon, ladies and gentlemen, or good morning, or good evening, depending on where you are in our tiny little world. Here in Ankara, Turkey, it's 4 p.m. in the afternoon, and my name is Dr. Umut Akyol. And I am an otorhinolaryngologist. I'm an ENT surgeon in Hacettepe University in Ankara. My subspecialty is paediatric otorhinolaryngology. I'm a pediatric ENT. And before talking about Hunter syndrome a little bit, I would like to, of course, thank Shire for giving us this opportunity to discuss this quite important subject for us. I told you that I'm a pediatric otorhinolaryngologist, and this is my best ever business card made by a 4.5-year-old young lady patient of mine. And some of my patients see me as a 5-star doctor, as you see. And I told you I will be talking about Hunter syndrome. As you have already mentioned, probably seen, I'm not a native English speaker, so please excuse my broken English, but I hope I can give you a couple of important take-home messages in about 15 to 16 minutes with a couple of slides. Then we will have a time for some questions and comments. I'm not a professional or experienced webinarist, but I know that you can send me your questions or your remarks whenever you want to, and I'll be trying to answer them if I can. So what is Hunter syndrome? I am an otorhinolaryngologist. I'm a pediatric ENT. I'm a surgeon. I'm not the one who will be talking and who can talk about, rare diseases or mucopolysaccharidosis. I'm not a pediatrician. I'm not a pediatric metabolic disorder specialist. But Hunter's is very important for us, the ENTs, pediatric ENTs, and we are also very important for Hunter kids, Hunter patients. And we'll see why in a couple of slides' time. Hunter is a mucopolysaccharidosis. Specifically, it's a type 2 mucopolysaccharidosis disease. It is a progressive, irreversible, and multisystemic disease with a high prevalence of early ENT manifestations. This is important, early ENT manifestations. It is very rare, as I told you. An estimated incidence of 1 over 162,000 live births is the incidence, and it's caused by abnormal building up of glycosaminoglycans. We used to call them mucopolysaccharides, but now the proper name is glycosaminoglycans, and I'm going to refer them as GAGs, as you'll be seeing in the slides from now on. Hunter's is an X-linked recessive disorder. That's why almost all our patients are male. And what happens that is very important for us, the ENTs, in Hunter's disease? I told you the GAGs accumulate in the tissue, in the soft tissue, and causes some malfunctions. When these GAGs accumulate in the adenoids or perieustachian tube tissue, soft tissue, and the middle ear, they cause some otological problems, some malfunctions. And most of these kids have frequent attacks of acute otitis media, recurrent otitis media with effusion, and hearing loss. When the GAGs accumulate in the tonsils, adenoids, and pharyngeal walls, and of course in the tongue, they cause obstruction. They obstruct the pharyngeal inlet and cause some serious problems regarding sleep. These kids are having obstructive sleep apnea syndrome or some serious diseases regarding upper respiratory tract obstruction. Of course, the GAGs not only accumulate in the pharyngeal area, but all around the upper respiratory tract, and especially as the disease progresses, causes some serious airway problems. And that's why they are quite important for us. They are the kids with high probability of having some serious complications during the surgery. And GAGs, when they accumulate in the body and the rest of the body and brain, they lead to skeletal and developmental abnormalities. And diagnosis of Hunter syndrome is not quite easy when the kids are born, because unfortunately symptoms are not apparent at birth, but usually start to become noticeable after the first year of life. And often these first symptoms may include abdominal hernias and frequent upper respiratory tract infections. And since these symptoms are quite common among all infants, they are not likely to lead a doctor if it's not, if he or she is not specifically got a couple of very important point knowledge in her or his mind to make a diagnosis of Hunter syndrome right away. So what is the role of the ENT specialist? What is the pediatric ENTs? Why are we very important? We are because we can help these kids, Hunter kids, as early as possible, to diagnose them as early as possible, so that we may improve the quality of life and life expectancy of these patients. We are the ones who see these patients very frequently and very early in their lifespan. And these are the kids coming to us every second week with upper respiratory tract infection, otitis media. These are the kids whom we have to prescribe antibiotics every month because of an otitis media or any other kind of upper respiratory tract infections. We see these patients before they get the diagnosis. That's why ENTs are very important. And if we can catch these kids as early as possible, if we can diagnose them as early as possible, they will probably have a longer, healthier, happier life with a much improved quality of life, not only, of course, for themselves, but for their families and for the society too. That's why it's very important to diagnose them as early as possible. And we can do that. As you can see here, the key specialist involved in MPS II diagnosis based on patient age and symptom presentation, we are the ones with general pediatric surgeons who see these patients very early, when they are little babies of 1 year or 2 years of age, because they have frequent attacks of upper respiratory tract infections, otitis media, nasal obstruction, enlarged tongue. And they have hernia. That's why they go to the pediatric surgeon. Of course, when the pediatric neurologist or the endocrinologist or the cardiologist or the orthopedic surgeons see these kids, unfortunately, it's a little bit too late. When they are 5, 6, 7 years of age, the disease progresses, causes some serious, irreversible morphological changes, and we may not really help these kids anymore after this stage. So what should we be looking for? Hunter's kids are different. They have different facial and body features. They have large head and distinct facial features like thick lips, broad nose and flared nostrils, excess facial hair, prominent supraorbital ridges, large jaws. And as they grow, they will have probably a short stature and short trunk and neck. But not only these, of course, they will have developmental delay. Most of the kids will be having some speech delay when the CNS involvement is present. And orthopedical features, orthopedical malformations like claw-like hands. Carpal tunnel syndrome is very frequent in these kids, and as well as joint stiffness and contractures. Before these features develop, it is important to look out for unusual clusters of symptoms. Because remember, we have to diagnose them as early as possible before the morphological changes really took place. Or individual occurrences of unusual symptoms are also very important too. ENT physicians, we play a crucial role in diagnosis because almost all these kids have involvement of head and neck or ear, nose, and throat. More than 90% in the head and neck region, more than 60-80% in the ear or mouth. They have glycosaminoglycans, GAGs, accumulate all over the head and neck region. And this is also very important because the median age of diagnosis of Hunters globally is a little bit more than 3 years of age, 3.5 years of age. But we are seeing these patients much earlier. We see them when they are 6 months old, 9 months old, 1 year old because of frequent attacks of upper respiratory tract infections. Otitis media. Almost 75% have the otitis media. Nasal obstruction, facial features, 95% have them when they are 2 or 3 years of age. And if we can catch them at this period, we can diagnose them before the median diagnosed time, which is 3.5 years of age, and we can help them much better. Several ENT-related symptoms present by this age, including otitis media, nasal obstruction, enlarged adenoids, tonsils, and tongues obstructing the upper respiratory tract. What should we do? Keep in our mind that frequent attacks of upper respiratory tract infections, ear, nose, and throat infections, plus hernia may lead us to diagnosis of Hunters. That's why we have to check for hernia. I'm an ENT surgeon. I do not know how to check the hernia, and the pediatricians do that regularly. But please keep in your mind that almost 80% of the patients have hernia and 90% have enlarged spleen and liver. And almost half of these kids had already undergone hernia repair surgery. This is a very important point for us to keep in our mind. Otological problems. 70% of them almost have hearing loss, and 3 out of 4 patients have recurrent otitis media. That's why they are the patients whom we put indication for ventilation tube placement and or adenidectomy very early in their lifespan. That's why we have to check the history of upper respiratory tract infections, otitis media. That's why we have to perform a proper ENT examination with otoscopy if you have your sources, with pneumatic otoscopy, tympanometry, and audiology. And adenotonsillary hypertrophy obstructing the pharyngeal inlet is very important too. That's why we have to, check these kids' upper respiratory tract very carefully. Almost half of them have undergone adenidectomy or 1/3 tonsillectomy at 3 or 4 years before 3 or 4 years of age, which is again very important. And enlarged tongue is also quite prominent in these kids. 70% of them have an enlarged tongue before 3 years of age or at 3 years of age. That's why we have to check the history for sleep, snoring, and obstructive sleep apnea. We have to assess tonsils and adenate hypertrophy, enlarged tongue, obstructive oropharynx. And what I do regularly and what I do believe that we should all doing is performing flexible scope, flexible nasopharyngeoscopy, nasopharyngolaryngoscopy. These kids also have some serious dental disorders, and as you can see here, some peg-shaped teeth and hyperplastic and hypertrophic gingival tissue will be very prominent as the disease progresses. Airway problems can be serious, causing not only obstruction but some lower respiratory tract infections and serious problems. There is an indication for airway surgery in these kids, but the main thing is try to operate these kids, do this in airway surgery as soon as possible, as I told you, before the disease progresses and irreversible morphological changes take part. Because once the disease progresses, these kids become very vulnerable for some serious complications. They are the dangerous kids that you don't want to operate in an operation room. They are the ones who have all kinds of serious complications, sometimes with a high rate of morbidity and some mortality, unfortunately. That's why we have to be very careful. We have to catch them as soon as possible and treat them in terms of ENT, operate them as soon as possible. Upper airway obstruction may lead to serious complications, some recurrent respiratory infections, difficulty in intubation and extubation. That's why we have to check the history and assess the narrowness of the upper respiratory tract, low nasal passages, enlarged turbinates, and don't forget to perform flexible nasopharyngoscopy. Flexible scope is very important, and if you can please document, it's important for documentation too. If you can take a video or some pictures out of it so that you can see the progression of the disease by time. Even some serious, operations cannot control the airway, as you see here, because of even after a trach, the narrowed and tortuous trachea often obstructs the upper respiratory tract infection. Or you can see that serious subglottic stenosis or deviated trachea. And you can imagine that it's very hard even to intubate these kids in the operation room. That's why they have serious complications and high rate of morbidity and mortality in the operation room and in the early postoperative period. This is a video of a scope that I do regularly in my outpatients department. Please note that swelling, that edematous upper respiratory tract infections, and the adenate tissue here. And another very important thing is notice the laryngeal cords here. They are edematous, the GAG accumulation causes some enlargement, and you can imagine the voice of this tiny little baby is almost like a 40-year-old smoker, rock star, very tough, very coarse because of that accumulation, and that chronic laryngitis looking edematous tissue. And this is because of GAG accumulation. And this causes some serious respiratory complications again. They are frequent, they represent a cause of high morbidity and mortality in these patients. We have to keep them in our mind. So what if we suspect a Hunter syndrome? This is, again, the most important thing. We have to keep in our mind that frequent attacks of upper respiratory tract infections, common otological problems, recurrent respiratory infections, otitis media with effusion, chronic or recurrent otitis media, plus presence of hernia must alert us. A light bulb in our brain must be, lit very bright, thinking that this kid may have Hunter syndrome, because togetherness of these two symptoms, frequent attack of upper respiratory tract infections, plus hernia, is present very early in most of the Hunter kids. That's why when you have a patient with frequent attacks of upper respiratory tract infection plus hernia, please refer these patients to a specialist as soon as possible. And this is the main take-home message that I want you, if I can, to your practice today. If you will have some patients with frequent attacks of upper respiratory tract infections plus hernia, this can be a Hunter's. And if it's a Hunter, it is very important to diagnose these kids as early as possible. And we are the ones who can do that because we see these patients very early in their lifespan. There are quite a lot of information in the web that you can reach, as you have seen in these slides, regarding Hunters. And now I know we have some time, and I'll be very happy to read and hear your questions or remarks or comments regarding Hunters, and I'll be trying to answer these questions, of course, from a point of view of an ENT surgeon. As I told you, I'm not a pediatrician or I'm not a metabolic disorder specialist. Questions. Okay, I have to read them first to you. There are a couple of them here. A colleague of mine is asking, let me read the question to you first. It is clear that early recognition and diagnosis can transform the prospects and quality of life of a child with Hunter syndrome and that of its parents. What are the two key symptoms that ENTs should look for? Abdominal hernia and otitis media. What about an enlarged head, pre-developed? Okay, enlarged head. I told you, the main two things, the togetherness of hernia and frequent attacks of upper respiratory tract infections is very important. These two things, this togetherness of these two things must alert us. This is very important. The enlarged head, the morphological changes, the supraorbital rims, excess facial hair, they are not present in the first year of their life. So when they are present, it's becoming a bit late. Some patients' parents were telling me that even from the first months of their lifespan, the babies were a little bit different. They were not, the neighbors were coming home and saying that they were not like the father a little bit, they were not like the mother a lot, a little bit different. But it's not easy to catch a Hunter syndrome before 1-2 years of age. That's why the most important thing for us, for the ear, nose, and throat surgeons, for pediatricians, is togetherness of frequent attacks of upper respiratory tract infections or hernia, or of course history of hernia or TNA surgery and tube surgery. And of course enlarged head is a very important point, but it may be a bit too late. Okay, there is another question here. Let me read it to you. Are the symptoms and prognosis the same on the very rare occasions when Hunter syndrome affect a girl? Ooh, I am an humble surgeon. I am an ENT surgeon. I'm not a pediatrician. I'm not a pediatric metabolic disorder specialist. I really do not know about that quite scientific, deep parts of that genetics. But I know that it is very, very rare to have a female Hunter. And if we have more or less the symptoms and the morphology is same with the male ones. But of course, if you have such a deep question, you have to refer your, I will advise you to talk with your metabolic disorder, pediatric metabolic disorders specialists. Another question is, in the instance where a newborn boy has an older brother with Hunter syndrome, what are the immediate next steps for an ENT the moment the younger brother presents with constant cold and a blocked nose? Is there common sense in referring these babies to a geneticist even before these symptoms occur? Well, again, I am an ENT. But if I have an Hunter's kid in a family, I know this is a X-linked genetic disease. And if there is a sibling or there is a brother, sister having symptoms of upper respiratory tract infections, or if I'm suspicious a little bit, I will immediately refer him or her to a specialist. I know that this is a genetic disease and there is a good chance of the other members of the family to have the same disease. So what I will be doing as an ENT surgeon will be referring the kid. I don't know whether it is the right thing or not in terms of pediatricians, but this is what I'm going to do, and I think that it's quite reasonable. Another question. With such a systemic progressive disease, patients can get lost between medical specialists and ISMs. What are some useful strategies that ENTs can employ to support patients as they journey through this difficult disease? Again, another tough question, not for an ENT surgeon. But I can tell you that this is a multidisciplinary disease. This is a team work. I mean, we have to work in a team, especially we the surgeons, because we really do not know much about the pediatrics, pediatricians, how to feed these kids, how to, examine these kids. We are having our education on adults. Even us, the pediatric ENTs, we really are not pediatricians. And especially these kids are very vulnerable, very specific. That's why we have to work in a multidisciplinary environment. We are not the leader of the team. The leader of the team is the metabolic disorder specialist. That's why my advice will be taking care of the patients and the families together with the rest of the team in a multidisciplinary environment, but the leader mustn't be an ENT. The leader is the pediatrician, or if you have the pediatric metabolic disorder specialist. Okay, another question, let me see. Is disease progression faster in any particular feature? Is disease progression particular? I don't know. I'm an ENT. I only operate on these kids. I cut these kids. I'm not a pediatrician. I'm not even a scientist in these terms. I'm a pragmatic ENT surgeon. And that's why, again, we have to be in a team. We have to work multidisciplinary in order to answer these questions, in order to answer the demands of the family and the patients, and more important, in order to run away from the serious complications and morbidities and mortalities. That's why we have to be together with the pediatricians, pediatric pulmonologists, pediatric anesthesiologists, ICU unit specialists, intensive careists. They are very important so that we can take care of these kids all together, and some of us can answer questions like this. Okay, another question. What is the impact of early diagnosis and the potential for the quality of life of the child identified at 1, 2, and 3 years? Another good and tough question. The thing, again, is diagnose them as early as possible, because as the disease progresses, some morphological, irreversible changes occur, and they are there to stay. I'm not talking about, we cannot talk about the treatment of the disease, but if we catch them as early as possible, we or our pediatrician colleagues, metabolic disorder colleagues, can at least control the disease and prevent this fast deterioration and progression of the disease that causes and that gives us serious problems regarding airway and complications. That's why the earlier is the better. And we are the ones who can do it, because we are the ones who see these patients very early, when they are babies. If they have common colds, if they have frequent attacks of upper respiratory tract infection, if they have enlarged tonsils, recurrent recurrent otitis media and hernia, referring them to a specialist and catching them as early as possible is, of course, very important. 1 year is better than 2 years, 2 years better than 3 years. Let's see if we have some more questions here. Well, I cannot read any more questions in my laptop, but I'll be very happy if you have some. Please send it to me. We still have some time to answer these questions and for your remarks, and if you have for your comments regarding this disease. And if you do not have, again, the take-home messages for this tiny little talk is frequent attacks of upper respiratory tract infection plus hernia must ring the bells in our mind to catch a Hunter's disease patient as early as possible, or history of hernia surgery and or history of ear, nose and throat surgery, adenotonsillectomy and or tube placement. Most of these kids have these togetherness early in their lifespan, and we see them. Again, that was the message, and I hope I did able to, send it to you. If you want to reach for more information, the information on the screen at the moment, at the web, or your metabolic disease or pediatric metabolic disease specialists will be very happy to help you regarding Hunter.